Good day to you. Today I'm going to talk about pain therapy. My name is Dr. Yasser Osman. I'm an assistant professor in anesthesia and pain therapy, Alexandria University. So we'll begin this lecture by talking about pain. What is pain? Pain, we can perceive it as the alarm system, the natural alarm system of the body that alarms us that there is a danger or a damage in a certain part or to a certain part of the body and should be handled carefully. The scientific definition of pain is unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describe it in terms of such damage. Well, another very important concept, which is nociception, which is a traumatic or noxious stimuli that can cause pain. Well, we should put in mind that all nociception produce pain, but not all pain result from nociception stimulation. Well, pain may be classified into a very different way of classification. We can use the pathological causes of pain, we can use the etiology of pain, we can use the affected area to classify pain, but the most important is that we have to classify pain according to acute pain or chronic pain. What is acute pain? Well, acute pain is caused by noxious stimulation, usually. It is due to injury of a certain part of the body, whether it is superficial or deep. Acute pain produces a neuroendocrine stress response, which is very important in our field. Most pain comes from post-traumatic or post-operative. This is very important for the anesthetist. Obstetric pain and pain associated with medical illness as myocardial infarction. Most of the acute pain is self-limited. Types of acute pain can be classified as somatic pain, which may be superficial or deep, or visceral pain that result from disease or abnormal function in the internal organ of the body. Four physiological processes are involved in this pain process. Well, this diagram shows the four process, which is transduction, the initiation of pain from stimuli, then the transmission of this stimuli through the nerve fibers, then the reception and perception of the pain in the brain, and the final is the modulation, which is a process that can either make us feel pain more or less, and this occurs through all this pathway. This is important. Why? Because from this diagram it shows that we can manage pain in these four phases. For example, the transduction, we can give non-steroidal anti-inflammatories or opioids. In the transmission phase, we can give local anesthetic or opioids. In the modulation, we can give opioids or any other non-steroidal anti-inflammatory drugs. And in the perception, we can give opioids or the general anesthesia. And all of these reduce the pain sensation that the patient can complain of if he or she was subjected to a painful event. Well, what about chronic pain? Chronic pain now is pain that persists beyond the usual course of the acute one, which is usually from 1 to 6 months. Chronic pain may be due to nociceptive conditions or neuropathic conditions or mixed conditions. There is an element which is very important in this pain, which is the psychological mechanism of this pain, which plays a major role in chronic pain. The neuroendocrine stress response does not exist in most of the cases in this kind of pain. Most common forms of chronic pain include the nociceptive, which is an example of it, like the musculoskeletal disorder, which is primary nociceptive in origin, or the primary neuropathic, for example, the central neural disorders or peripheral neural disorders, or mixed, like cancer, pain, diseases. The pain pathway is also very important to discuss, and this is a diagram that shows the pain pathway. Just we will look at it quickly. The first order neuron lies here, the second order neuron, and the third order neuron. You should know more details about this, and you should by now have the previous lecture that talked about the physiology of pain, and you should have done this already. Now, what about the pain management, which is the main topic of this lecture? When we talk about management, we have to know two important elements. The first element that we should cover is the diagnosis. The second element is the treatment. How to diagnose pain? Okay, so how can we diagnose and evaluate pain? Well, first of all, we have to have some idea about the history of that pain and the quality of the pain, the onset of the pain, what caused the pain, what exacerbates this pain, and what makes the pain less or decrease the intensity of pain. This is very important. So the next step is to examine the patient to know the apparent causes. Is it tender? Is it pain due to a certain, for example, operation, certain trauma, or is it like a chronic pain? During the examination, we should really differentiate between acute and chronic pain, because when we talk about chronic pain, we should also evaluate the psychological component of the patient and if this pain can cause any disability to the patient from the occupational or from the social point of view. Also, we should do some examination that help us to diagnose this pain, this intensity, this type. And we can use also imaging studies like CT and MRI and X-rays to confirm our diagnosis and to reach a conclusion of what kind of pain we are dealing with. Now, after we done all of that, we should have a plan how to treat this pain. This pain can be treated either pharmacologically or by some sort of procedures like nerve blocks, local anesthetics, or neuromodulation technique, or multidisciplinary technique. Let's start with the pharmacological approach. Well, any pharmacological approach should be considered for pain treatment, should have some sort of a concept, which is a multimodal analgesia concept. The multimodal analgesia means that we use multiple analgesics in different concentrations and that have different mode of actions to decrease its dose and to decrease the side effects and have a better outcome of analgesia. Also, in the multimodal analgesia include some non-pharmacological intervention if needed, and this may improve the outcome of our management. Now, we should know that the pain is a complex phenomenon and should not be regarded as just we are treating the pain as a symptom and that's it. No, there is an underlying cause, and this pain or result of pain can cause problems by itself, like psychological problems that should be dealt with, or even some disabilities that we must put in our consideration. In the old days, the WHO proposed a ladder way of management of pain. Like for cancer pain, we use the simple non-opioid analgesics, then the non-steroidal, for example, the non-steroidal, and move towards a stronger and stronger drugs that cause more analgesics, like for example, morphine. But nowadays we use the multimodal analgesia technique, which I have just described before. Now, when we talk about pharmacology, we have to consider two important things. The pharmacokinetics of the drug, which is how the body affects the drug. For example, the mode of administration, the absorption, and the metabolism, and the excretion of the drug. And the pharmacodynamics of the drug, how the drug acts in the body, the side effects, and the action of the drug that we need the drug to perform. We should do that to all the pharmacological drugs that we use, either in this lecture or in general. Well, we'll give some examples of these pharmacological drugs that we use for analgesia. One of the most famous ones is the acetaminophen, which is the paracetamol. It can be given orally or as an intravenous preparation. This is very useful in the post-operative period, especially, and in the ICU patients. But paracetamol has its own side effects, which may be hepatotoxicity in a high doses. So, should we give this drug, caution should be taken. Now, another very famous drug, analgesic, that we all use is the non-steroidal anti-inflammatory drugs. The non-steroidal anti-inflammatory drugs can be taken in several forms, including intravenous, orally, or even suppositories. It has an analgesic, antipyretic, and anti-inflammatory properties, but unfortunately it is not without side effects. Some of the most important side effects of non-steroidal anti-inflammatory drugs is stomach upset, heartburn, and nausea. So, some patients may have problems taking these drugs, like patient with ulceration, like duodenal ulcer or peptic ulcer, and care should be taken for these patients. Opioid is another example of analgesics that we use frequently in the intraoperative and postoperative, and we also use it for chronic pain management. Opioid can be absorbed orally and easily absorbed from the GIT, or can given parenterally or in other means, as we are going to see again. Some example of opioids we use is codeine and hydrocodone. Tramadol is a very popular drug. Fentanyl also is a very popular drug, and hydromorphine. Unfortunately, the use of opioids come with a price because it has some side effects. Whether we use it orally or systemically, it has the same side effects. Excessive sedation, for example, nausea, and constipation is some of these side effects. Sometimes we need to administer stool softener and laxative for the patient with chronic opioid users. Well, also opioid can develop tolerance, meaning that we need to increase the dose of the opioid given to give the same result of analgesia by time. There is also the problem of the physical and psychological dependence, although the psychological dependence is not very common for cancer patients. Now, this is a diagram that shows the different pharmacological effects of opioid with its side effects, namely the behavioral, the psychological, the respiratory effect, and the muscle like seizures, sweating, hepatitis, gastrointestinal from constipation, and so on. What is the different mode of opioid administrations? We can give opioid in different ways. For example, intravenous opioids or spinal opioid therapy. We can inject opioid in the CSF to induce some analgesia. Transdermal opioid, like what we call a transdermal patch or Durajasic patch. This is given for patients with chronic pain like cancer patients, and this might help them because it causes slow release of the opioid over a period of time and cause steady analgesic levels. Another thing that I want to talk about is the patient-controlled analgesia. What is patient-controlled analgesia? The concept is to make the patient administered a certain pre-calculated dose of analgesia when he needs it by giving him a switch or a button that he presses. Then a machine will give the patient this preset dose of analgesic to relieve his pain. This is very popular in the post-operative period and in patient in the ICU. The patient usually have the confidence of when he feels pain, he will take the dose needed to reduce this pain, which makes him rather satisfied. This machine may be mechanically or electronically computerized to do so. It is programmable in such a way that the patient only will receive a certain amount of drug and does not exceed the drug calculated by the doctor. What about other pharmacological drugs that we give to reduce pain? We can give also antidepressant, which is very important in some cases. We can give anticonvulsant, antispasmodic and muscle relaxant. We can give cortisone in different way, but we should put in consideration that cortisone have some side effects, including hypertension, hyperglycemia, and even some cushingoid feature may appear in these patients who receive chronic cortisone or high doses of cortisone for a long time. We can also give local anesthetic. This might help in some cases. Alpha-2 adrenergic agonists. The most important, the most famous is clonidine. We can give this either in the epidural or in the intrathecal, or we can even give it as intravenous. Diagnostic and therapeutic blocks. What does this mean? It means that we perform nerve blocks that to the nerve that we think it causes pain. And if this pain disappears, then we have diagnosed the source of pain that we are looking for. Also, it is considered as a therapeutic approach to decrease such painful condition. Some of these examples is somatic nerve blocks, sympathetic nerve blocks, and epidural blocks and injections. To perform these drugs, we may use fluoroscopy, which is a technique in which we use X-ray to diagnose and see the bony structures and the anatomical landmarks. Also, we can inject a radio-opaque dye to diagnose and delineate the nerves that we want to work on. We should be careful for the amount of radiation we are exposed to, and we should wear like a shield to protect ourselves from the excessive amount of radiation, because this X-ray is multiple, and we take multiple pictures to locate exactly the anatomy that we want to inject the solution or the nerve with. Also, we may use ultrasound to guide the procedure of the block. It is becoming more popular, and because of its safer, it has no exposure to X-ray, and it also can visualize the vascular and neural anatomy, so it can decrease the incidence of the complication like pneumothorax or intraparenteral injection of the local anesthetic. This is a picture showing us the ultrasound guided interscalene block and how we perform it. And here the structures is quite clear, and as we can see the needle also, and we can see the needle approaching the structure we want to inject the local anesthetic with. Another procedure that we may resort to treat pain is the radiofrequency ablation. We can also use cryoneurolysis. What is radiofrequency ablation? Simply, we use the fluoroscopy to direct a needle with a tip that can be heated. This tip, when it reaches the desired nerve, it causes sort of ablation to that nerve, and so it will prevent the nerve from conducting the painful stimuli. The same way we can use cryoanalgesia or cryoablation. Instead of heating the tip to a certain degree, we freeze the tip to a certain degree, so the nerve that we submit to this very low temperature can also stop transmitting the painful stimuli to the patient. Another way to do this is the chemical neurolysis. Simply, after we use the fluoroscopy to delineate the nerve that we want to work on, we inject some local anesthetic just to make sure that we are in the right position. Then we inject a chemical like alcohol or phenol to do the neurolysis to that nerve. This technique is used mainly for intractable cancer pain. Some of examples of this chemical neurolysis like celiac plexus block and lumbar and sympathetic chain block, and hypoglycemic plexus also. But this technique has a considerable morbidity in a way that it can cause loss of motor and sensory function of that nerve. Some other techniques are used like neuromodulation, which is an electrical stimulation to the nervous system. This stimulation can produce analgesia to the patient, whether in acute or in chronic pain. This stimulation can be transcutaneous, which is called TENS, very common, especially in obstetric and back pain, epidural, or electrode implanted into the central nervous system. Multidisciplinary therapy or treatment, which is considered to be useful when we treat pain as a whole syndrome. So we can consider the psychological intervention, for example, cognitive intervention or behavior therapy. We can consider some physical therapy whether cold or heat appliance to the part that is painful, or even acupuncture. This is some links that additional learning materials, some videos of mine that can give you some idea about local anesthetics and ultrasound nerve plexus blocks, regional anesthesia in general, spinal and epidural anesthesia. This might add some very important information to you. I recommend that you scan these codes and see this lecture. It might help you in better understanding of the pain management therapy.